We're delighted to have Wendy Bailey here, Director Bailey. I know she's been before the Senate before, and but we'll cover a few different topics this time. So if I could have your attention, please. All right, we got a lot to cover. The House goes into session at 2, so we'd like to have time for questions. Director Bailey, the floor is yours.
Okay, thank you. So I have a few slides for you as a handout. Can you hear me good?
Into the microphone, please.
Make sure I don't.
Okay, is that better?
We have a much better sound system on the House side than the Senate, so yes.
Okay. Well, thankfully
Talk about a low standard.
Well, thankfully I have a really loud voice too. So you have a few handouts that I want to walk through today. I was asked to just provide you an overview of the system and where we are. I wanted to start off by just giving you an overview of what the state's mental health system is, which is that first slide that you see. And if you've heard me present before, you've heard this before, but Mississippi's mental health system is comprised of 3 components. You have state-operated programs and community service programs that are at the 11 Department of Mental Health program locations across the state that provide 24/7 care. And then you have regional community mental health centers, which there are 11 in the state, and they're part of local county government. And then you have other nonprofit, for-profit agencies that are Department of Mental Health certified providers. There's about 128 certified providers across the state. The Department of Mental Health has about 650 grants that we administer to providers across the state as well, and about 79 to 80% of that goes to the community mental health centers because they are the main provider of those community-based services. On any given day at our behavioral health programs, there's about 950 people receiving services. That includes acute psych, forensic, the nursing homes. That includes child and adolescent programs and chemical dependency services as well. And then on any given day, there's about 1,250 people at the IDD regional programs and the community homes receiving services as well. And again, that's 24/7 care. We also have responsibility for the IDD home and community-based waiver, and there's around 2,700 people that are receiving those waiver services across the state, and the 1915I for people who have intellectual and developmental disabilities, and that's about another 1,100. The agency also credentials about 3,500 employees throughout the behavioral health workforce through the PLACE credentials as well. So I wanted to just briefly talk through a few of the progress that's made, the challenges that we are facing, and then some opportunities as well. The slide the next slide gives you a breakdown of the Olmstead litigation. As you know, back in 2011, the state received a findings letter from the Department of Justice. In 2019, there was a trial, and in 2020, we had a special master, Dr. Michael Hogan, that was appointed to work with the state, and we worked with him very closely over the next 2 years. And then the state decided to appeal the district court decision, and in October of last year, the Fifth Circuit ruled in favor of the state. As I've mentioned before, one question that I get is, how does that change things? Because the decision was overturned. And as I've said many times before, it doesn't in the way of progress and our goals and our vision for moving forward in community-based services. The next slide, I wanted to give you just a little bit of an overview with how Mississippi's comparing nationally. So the main one that I want to point out is access to care. So in access to care, Mississippi is 42nd in the nation, compared to 47th in the previous report, but still it's 42nd in the nation. That measure is based on access to treatment, the quality and the cost of treatment, access to a mental health workforce availability. It's a wide range of measures. Also, in the overall ranking, Mississippi was 25th in this State of Mental Health America report compared to 36 in the previous report. So while we still have a ways to go, there are some improvements in some of these areas. The other one I really want to point out is that mental health workforce availability. And in the nation, we're 42nd in having the mental health workforce that we need. And you can see that in this slide with the decrease in the number of employees. This is only at the state-operated programs, but you can see that there's been an overall decrease of about 1,000 employees just since May of 2020. To provide you with a few highlights from the last fiscal year, there was a 9% increase in the number of admissions to the state hospitals. So we have 4 state hospitals in Mississippi with a total of 320 acute psychiatric beds. And you access those beds through the court commitment process. And there was a 9% increase in the number of admissions to the beds last fiscal year. One of the reasons for that increase was due to reopening some beds that had been temporarily closed due to staffing challenges. We were down 30 beds at East Mississippi State Hospital and 20 at Mississippi State Hospital. And about halfway through that fiscal year, we were able to reopen those beds. So you thus saw that increase in the number of people who were able to be served. But if you look over 10 years, there's been a 33% decrease in the number of admissions to the state hospital based over the last 10 years, where the focus has been on expanding community-based services. So you can see that the community services are working because you are seeing a decrease in the number of admissions to the hospital. You can also see here a highlight for something related to the decrease in the wait times. So the wait times, especially during the COVID pandemic, we had up to an 11-day wait for access to a state hospital bed. And the wait now in FY23, it was down to 5 days. The wait now is around 4 to 5 days once we get a commitment order for access to that state hospital bed. So it has decreased by about 55%, but we want to continue decreasing that wait time. The residency program is something that the legislature has made a priority in funding. Again, it goes back to the issue with workforce development. We know there's not enough psychiatrists in the state of Mississippi. So back in July of 2021, Mississippi State Hospital began a residency program. And they started with 6 residents, and then in July of 2022 added 6 more. In July of 2023 added 6 more, and the plan is to do the same in 2024. The goal is to keep those residents in the state of Mississippi once they complete that residency. It also allows them to have the opportunity not just to benefit from acute psych experience, but you have forensic services at Mississippi State Hospital, you have a substance use disorder unit, and you also have Oak Circle Center for Children and Adolescents. So it's giving those residents a well-rounded exposure to the different services. And just to kind of put this in perspective for you, the first year there were 50 applicants, and last year there were over 500 applicants. So interest in the program has definitely progressed. Some community services highlights that I just want to briefly mention is intensive community support services. So this has been a priority for the agency and the community mental health centers over the last several years, is to make sure that each county has access to some level of intensive community support service. The placement of these PAC teams and I-Court teams and ICSS were based on the number of commitments in counties. So you can see in this past fiscal year that right at 800 people were served by the PAC teams. We have 10 PAC teams in the state, and that's the highest level of service. So out of that 796 exactly people that were served, 7% had to go back to a state hospital. The reason this outcome is so important is the people who are served by PAC teams have had multiple admissions to the hospital. So You're serving individuals who have been through the doors of the state hospital multiple times. And to be involved and wrapped in those intensive services, only 7% having to be readmitted in the year is an excellent outcome. I-Court teams are very similar to PAC teams. They're catered a little more for rural areas of the state. And again, you can see there, we have 16 teams. They have a smaller caseload, but you had 8% that were readmitted to the state hospital as well. So overall, there were 2,215 people that received those intensive community support services that had been received services at a state hospital before as well. You also can see 708 people were served through supported employment. We know it's not just the outpatient therapy, it's the other components as well that leads to someone's success in recovery, and that's things such as supported employment and having housing and having access to crisis services. So that's the next thing I wanted to mention. All of the community mental health centers have a mobile crisis response team. And in this last fiscal year, there were 9,877 calls and 2,100 face-to-face responses. You've probably heard me mention 988 before, which is a 3-digit behavioral health crisis line. It's a national line. We have 2 call centers in the state of Mississippi. So now you can call 988 and get a trained counselor 24 hours a day, 7 days a week. If you need additional response, 988 can dispatch and contact that mobile crisis team as well. So they're working hand in hand. The admissions to the CSUs, I also wanted to highlight because I know that's something that is often discussed. There's 13 crisis stabilization units across the state with 180 beds. These are short-term treatment that can be accessed voluntarily or involuntarily. So there were 3,400 admissions last fiscal year, and 92% were diverted from a higher level of care. So that means 92% of the time, the person who went to the crisis stabilization unit did not have to go on to the state hospital, which is what you want to see. This slide I just want to show you because this is ultimately what you want in a crisis system. So you have a person in crisis, you can see at the beginning of the slide, and if they're in a crisis situation, they need someone to talk to. And that's where 988, the crisis line, comes in. 80% of the time, the crisis can be resolved by talking to someone over the phone. 20% of the time, it cannot. And these are national statistics, but they also fall in line with what we see in Mississippi, too. So that 20% of the time, they're going to need some type of response. And that's where the state, the legislature, is funding mobile crisis response teams at the community mental health centers. And they can go out into the field where the person's experiencing the crisis and provide that service. 70% of the time, that can be resolved in the field. But sometimes you need a higher level of care. So you need someone to talk to, someone to respond, and in those situations, you need somewhere to go. And that is where the crisis stabilization units come in. That's where local hospitals, a private acute psych, the state hospitals, this is your somewhere to go. The other key component is when you are discharged from where you were staying, that post-crisis wraparound care is so important because that's what helps you remain stable in the community. That's where we want you connected to things like PACT and I-Court and ICSS, so you have those services available to you. You can see when you have these components of a crisis system, you see a decreased use in jail, emergency departments, inpatient hospitals. You'll also see this end of the spectrum is least restrictive and least costly. As you go down, the state hospitals is your highest level of care and your highest cost as well. On CSU admissions, this is very new data, but I wanted to share with you. The crisis stabilization units, the Department of Mental Health has been working hand in hand with the community mental health centers to try to increase the number of people that they can serve in the crisis stabilization units and decrease the denials. So we were able to shift funding from the state hospitals to provide a grant to the CSUs to help with safety measures or increased staffing needs to where they could accept sometimes more difficult clients or clients that have a higher level of need. So that has been a focus, and you can see if you compare the mid-year of FY23, so that was last fiscal year, to the mid-year of this fiscal year, we've seen a 16% increase in the admissions to the CSUs already and a 33% decrease in the denials. So this is something that we're working on very closely. We received some national technical assistance, which is providing us with recommendations on how to help the CSUs to where they can take some of these admissions as well, and just assistance and training that we could provide too. On people waiting in jail. So when we receive a commitment order for the state hospital, that's when we start where the wait time is. So you can, right now, the average wait in jail, once we receive a commitment order, is about 2.7 days. Mississippi State Hospital is a little less than that. It's usually like 1.52 days. North Mississippi State Hospital and South Mississippi State Hospital, which only have 50 beds, is a little bit, sometimes like a 3 or 4 day wait. So the average is 2.7 days. That's once we receive the commitment order. There has been a decrease, a 34% decrease in the number of people waiting in jail with a commitment order if you compare FY24 first quarter to the second quarter. There's been a strategic initiative to encourage people in local counties to work together to not hold an individual in jail, to look at all the resources that are available for them to use to see how we can make this process better. We do not want any person waiting in jail that has not committed a crime and they're just waiting for treatment. So this is a priority for all players. The state hospital acute psychiatric admissions, those are up as well. So you can see here, mid-year, this fiscal year, we're at 969 compared to 933 last year. But again, we have the additional beds. I wanted to briefly mention addiction services as well, because co-occurring is so common. Someone has a serious mental illness and they also have an addiction issue. So East Mississippi State Hospital has 35 beds that are for court commitment for substance use disorder. Mississippi State Hospital has 25 beds for females. There's also 624 beds in the community, which is residential treatment, that the state helps funds and is provided by community providers. And you can see there were 4,369 people served in those beds. Along with treatment, there's a focus on prevention. And for the second year in a row, the state of Mississippi has seen a decrease in the number of opioid-related overdose deaths. We were on the rise every year over about 10 years, and we're finally seeing a decline in that in the last 2 years. There's some concentrated efforts around Narcan distribution. We have a good partnership with the Department of Health on that as well, and the community mental health centers. And the Department of Mental Health provides Narcan to first responders, law enforcement officers, and substance use providers. And what it is it's if you have someone who is in overdose from an opioid related, it's a nasal spray, and you spray it and it reverses the overdose. You still have to get them very quickly to a hospital, but it's a fantastic prevention effort, and you can see the decrease. We distributed over 6,000 doses of Narcan just last year. It's also great for law enforcement to have, because you can have a situation where you've pulled someone over and the law enforcement officer may be exposed to fentanyl. So them having that Narcan available for themselves as well is key. The last thing on addiction services I wanted to briefly mention is, we focus on mental health providers, but it takes the community. It takes everyone in the state working together. And we have a great program that we're partnering with the Mississippi Public Health Institute and 3 churches in the Jackson area, and we're expanding that. It's called the Congregational Recovery Outreach Program. And we go into churches and we train the church leaders in how to recognize mental health and substance use, and how to make connections to resources. We connect them to their community mental health center to be able to make referrals and just do overall education and awareness, because we know the faith-based community is very strong in the state of Mississippi. And we know many times people are going to turn to their local pastor or Sunday school teacher or faith-based leader maybe before they would a mental health professional. So that's something I'm excited to see. Okay, very briefly, I wanted to also highlight House Bill 1222 and some progress related to that. So last year, you passed House Bill 1222, and it had multiple components to it. One is court liaisons. So the court liaison was a pilot program that was started, and it really has 4 goals. It's to reduce the number of commitments to state hospital, reduce the amount of time that someone encounters law enforcement and the criminal justice system, increase the knowledge about community-based services, and increase collaboration with the families, the courts, law enforcement, the community mental health centers, the hospitals, for the benefit of the people that they serve. So through ARPA funding, general funds, and some federal funds, we've been able to fund 33 court liaison positions at the community mental health center. Right now, about 20 are filled. I got a text today that we filled one more, or they filled one more, so we're at 20 now. So there's still these positions open and on recruitment. It's master's level because they also are able to do the pre-evaluation screening. But I really want to point out this data right here. In FY23, and again, this is when it was a pilot, the court liaisons had an 88% diversion rate with the Chancery Clerk referrals. So when the Chancery Clerk referred the individual to the court liaison, who could then look at what services were available and how to help the family and the person, 88% of the time they did not have to have a writ issued or a commitment order. To me, this is the future of how we can, at the county and the state level, work together to divert people, but still make sure they're getting the care that they need. So we're seeing success in this, but it's still a new program. Law enforcement training is also part of this bill, this legislation. So this legislation requires mental health first aid training for all law enforcement officers, and that's an 8-hour training. We've had a train the trainer class. We have a training at the end of this month and scheduled throughout 2024. Crisis intervention team training is a 40-hour training. And that's an evidence-based or a best practice. And you can see there were 22 CIT classes in 2023, and there's already 25 CIT classes scheduled for 2024. If you talk to law enforcement officers who have been through CIT training, they will tell you it's a fantastic tool for them to have in their tool belt. It really teaches them how to de-escalate and then how to connect the person and avoid someone having to wait in jail. Another part of House Bill 1222 is Chancery Clerk reporting. So this legislation required that the Chancery Clerks report a core set of data to the department, and then we produce a report for you. There have been some challenges with this the first time go around. Chancery Clerks haven't had to report this data before, so it's new. The way that we did it is we have a bed registry. And the crisis stabilization beds and the state hospital beds are in this bed registry. And we gave the Chancery Clerks access to be able to go in so they could see where a vacant bed was. So maybe they don't have any beds at their CSU, but the closest CSU to them does. They could have that person receive treatment at that CSU. You do have transportation, which is an issue. We built the Chancery Clerk reporting into this system to encourage them to use the bed registry too, to encourage them to see where beds are available. So first quarter reporting, you have the report in your packet. And then we're hoping, I will be honest with you, I do not believe the data is accurate. You'll have some situations, and you'll see when you look at it, you've got some situations where you have more CSU denials than you did affidavits filed. So that's not possible. But I think that's because if a CSU denied for 3 reasons, they put a 3 So 3 denials for 1 person. So there's some things that we've got to work with them on. We just recently spoke at the Chancery Clerk Conference. We've been communicating with them. As with anything with data collection that's new, it's going to take a little time to clean it up. But it's good data to have. And we appreciate the relationship building it's created with the Chancery Clerks as well. So some legislative goals, and I promise I'm almost to the end. Some legislative goals that I wanted to mention is some changes to the civil commitment statutes to improve diversion and restrict the use of jails. You have a handout in that packet that shows the civil commitment process. It's this one right here. If you're like me, I'm a visual person, so this helps me. Right now, the process for civil commitment in the state of Mississippi is you have a brother and you are afraid that he's a danger to himself or others, and you go to the Chancery Clerk's office and you file an affidavit. And then the Chancery Clerk, there's a writ that's issued, and law enforcement goes and picks up that individual on that writ for a pre-evaluation screening that should be done by the community mental health centers. So, law enforcement has picked up your loved one on a writ before, in most cases, they've seen the mental health professional. So, what we are saying is we think there's a reasonable way to address this, also with a safety valve, and that is you take this 3rd step right here and you move it to the beginning. And this is modeled off of some other states as well. So the individual goes to their local mental health authority, to the community mental health center, so the mental health professional is able to see the person first. Now we know that there's going to be some situations where that's not going to work out. But we have the mobile crisis response teams in our state. And in many states, the mobile crisis response teams are doing the pre-evaluation screenings, and they're going out in the community and they're doing this. Now, we also know, though, there's going to be times and situations where that individual may be in a psychotic state and they're not going to talk to the person. That's where there's a safety valve where the affidavit can then be filed. But the person has the opportunity to be evaluated or to have the screening done by the mental health professional before the writ's issued. And I'm going to give you 2 quick examples, real world examples. I've had sheriffs that have told me that they have gone to pick up someone and they thought, why am I picking this person up? This person does not need this level of treatment. But he said, I have a writ that says I shall pick them up. So he said, I have to. I had someone call my office whose mother was in her 70s and had bipolar disorder and had stopped taking her medications, and she felt like she needed to be hospitalized. When she went to the Chancery Clerk's office, they told her, yes, here's the process, but law enforcement's going to pick your mom up. And she called me and she goes, my mother's in her 70s. I do not want her placed in the back of a cop car. Is there any other way that we can do this? So having the opportunity to do diversion and look at the crisis stabilization beds and the intensive community services and what else could be done before you get to the point of involving law enforcement, I think could be very beneficial. This is not to try to require families to have to take extra steps to get their loved one treatment. It's really just to make sure that their loved one is receiving treatment and the option of being able to be served in a lesser restrictive environment, if that's possible. And then other legislative goals are around decreasing or restricting the use of jails as a holding location for someone. I think there's a lot of different opportunities in that area that we can look at. And then the Forensic Services Unit, IDD services, and then, of course, continuing to address the workforce challenges. And then I just gave you one slide at the end that shows you some of the goals that we're working towards. So that's increasing the CSU bed availability, but also the utilization of those beds and coordinating that across the state as well. Another thing that I just wanted to briefly highlight on this one is peer respite programs. Peer support services are phenomenal. As people who use their lived experience to help others, it's incredible. And peer respite programs, there's about 40 to 50 across the nation, and we don't have any in Mississippi. So we have provided 3 grants to start and pilot 3 peer respite programs in our state. And again, that's a place when someone is needing that respite that they can go to, and they're connected with a peer support specialist who's been there and who has that personal story of recovery that they can use. So I hope I did that as quick as I can for questions.
All right, thank you, Director Bailey. I've got a couple of questions.
Okay.
You talked about 988. What happens when a call comes into 911?
So we're working right now with protocols, and nationally it's being done too, looking at how to coordinate better with 911 and 988. And SAMHSA is looking at that on the national level, and we've spoken to the 911 directors, spoke at their conference, so that's still a work in progress. The main thing is to create awareness so people know they can call 988 instead of 911 if it is that behavioral health crisis.
So when a call comes into 911 and they do recognize it's a mental health issue, do they transfer it to 988?
They could, yes.
All right. And then on the civil commitment process, in the state of Mississippi, we require 2 signatures, which sometimes become burdensome. In some states, it's just 1 signature is required. Is that something we need to consider, in your opinion?
I do understand there's a workforce shortage, and I know that, but a civil commitment is a very serious process. You are determining that someone is a danger to themselves or others and taking their rights away for them to receive treatment. In some states where you have 1, you can see an increase in commitments as well. So that's something I think we would need to look at a little more closely to determine if that's the best thing.
All right. And you mentioned the inconsistencies of reporting, and I've asked you about this before, but there is no training for chancery clerks or chancery judges that I know of. Is that something that DMH needs to consider and require?
I think that could be very, very beneficial. We go to their yearly conferences and speak, but the legislature passed training that's required for the commissioners and for law enforcement, and chancery clerks and judges are involved in the commitment process as well. So I think it could be beneficial.
Senator Bryan?
I'll just say initially that in this area and a lot of others, it is very useful to have data and accurate data. And I don't understand much about how all these computers and everything work, but I do know that it's not a big deal to have come to Jackson, come to the state every day, the number of people that are in the commitment process and where they are. I know that it's not difficult to keep up with the actual school attendance in every school building every day in real time. And I'm sure there are other areas where this is applicable. And I think one of the things that we could do, which would be useful across the board, is just figuring out mechanically, how do you get people to enter data in real time? Because long term, it's in their own self-interest to do so. And I know we've talked about that. And I don't expect you to solve that right now, but before the end of the week. The other question I have is, and these are just things that I've noticed, the period of time that is permitted by law between the completion of an examination of someone who's been perhaps taken into custody and is being held theoretically against their will and has been examined, now has to have a hearing within 7 to 10 days. That's just an absurd length of time to allow someone to be held against his or her will without the opportunity to appear before somebody and say, I shouldn't be in here. And I don't know how to deal with this. I don't know if we have some sort of initial appearance within the first 24 hours or something, but certainly the hearing itself needs to be held more quickly. But in addition to the other issues with the process, it is, I don't care if you've been accused of a felony, I don't care what it is. If you're being held against your will, you ought to get in front of a magistrate really quick just to say, I shouldn't be here. And just the ability to do that, I think, will alleviate a lot of the really nightmare situations, which may be infrequent, but nevertheless, even though they're infrequent, the harm is very great. There is one thing I would ask you to do for me. There is this crisis system alignment of services toward a common goal with 80%, 70%, 65% off. I don't know what that means. And so I wish that you would, at some point, help us figure out exactly what it means when it says 80% are resolved on the phone, 70% are resolved in the field. I mean, how resolved? The other thing that would be useful, and this gets back to data, and I know y'all can do this, is we have the state hospital admissions by county. It'd be very useful to get that as a percentage of the county's population. And I think we need to remember that this is the county where the hearing was held, not necessarily the county of residence. So just in the ordinary course of things, you can expect to see a lot more commitments, I think, from more populated areas. But be that as it may, if you had a breakdown by population, you'd be able to see the outliers, and that's one of the things we're looking for in all of this. Thank you. That's all I have.
The gentlelady from Lincoln.
So I may have made the mistake of texting my sheriff during this because he has written back a mountain of things, but right now in Lincoln County, we have 3 that are being held for forensic that need to get to Whitfield. One of them has been there over a year.
So forensic, yes. Forensic is actually one thing that I've just briefly touched on, but it's that last bullet right there on the goals list. So right now, Mississippi State Hospital is the only inpatient forensic service provider in the state. And we were very limited in the number of beds. It was an old building at the hospital. It had 35 beds total. And competency restoration on average takes about 6 months for an individual. Those beds also included not guilty by reason of insanity and your initial competency exams. So the legislature helped fund what's going to be an 81-bed forensic unit. The renovations are already happening, and it should open in the fall of this year. So right now, there's about 118 people across the state waiting for one of those beds, for one of those forensic beds, which are separate and different from the acute psychiatric beds. So that is something that is absolutely a focus, and one of our budget priorities is to be able to staff that unit. So if you have 118 people waiting in an 81-bed unit that can open, you'll see it's going to quickly be able to help.
So you're saying that the forensic exam is 6 months long? Oh.
No, ma'am. So there's an initial competency evaluation. So that's to determine if you're competent to stand trial. If it's determined that you're not competent, you have to do competency restoration. Competency restoration can take up to about 6 months. That's restoring the person to competency to then be able to stand trial.
So I can
Right.
He's got at least 6 more months to go.
No, let me get his name to see where he's on the list. It's improving. We've been able to shift and open a few lesser secure beds. This unit is maximum security. So you've got individuals who have committed murder, and rape and arson, and it's a maximum security unit. Again, you've got individuals who are not guilty by reason of insanity. But we've been able to open some mid-level secure beds in other buildings at the hospital, just trying to improve that wait time and that wait list.
Gentleman from Harrison.
Director Bailey, what level of involvement do y'all have, if any, on cases like, say, the Alcorn County, where the gentleman was in jail for 14 days with possibly no civil hearing? Not sure on that. The point is, he perished in jail, had not committed a crime, and was seeking mental health treatment. Do y'all have any involvement in that whatsoever?
The involvement that we have is we do the training for the pre-evaluation screenings. So the individuals at the community mental health centers who conduct that pre-evaluation screening to see if that person is to the point of meeting the civil commitment criteria, we conduct that training. But we don't receive the court order to know about the individual where they're placed on the wait list for this Mississippi State Hospital until that court order's been issued, not during any of the other part of the process. So the pre-evaluation screening has to be done, you have the examination, you have the hearing, then once the order's been issued, that's when it comes to the Department of Mental Health.
So subsequently, if you have an incident like what happened in Alcorn County happen, who would be responsible for getting to the bottom of exactly what happened and why it happened?
In a situation like that, if we did not have a commitment order, I can't speak directly to it because of HIPAA, but if we did not have a commitment order, we would not know of the individual. But the state is funding and providing services that help through that process with the court liaisons and the crisis stabilization units. So there are state-funded services where outcome measures are set that are to help in those situations.
All right, thank you.
Director Bailey, in a previous hearing we had, and you were not involved with the hearing, but salaries of the director of the CMHCs came up, and apparently they may vary greatly across the state. One question is, how are those salaries set? And then do you know about the average?
The community mental health centers are part of county government, so each board of supervisors for a county appoint a commissioner. And then those commissioners make up the board for that community mental health center. So the Department of Mental Health, we have operational standards that they have to meet, and we certify them, and then we provide grant funds that have outcomes. But as far as the authority and the oversight, that's at the county level. So we don't set salaries. That doesn't go through the state personnel board or anything. That's done on the county level by that board of commissioners, which is the authority for that community mental health center.
And where do the funds come from that pay the salary?
It could be a mixture. I mean, it can be revenue that they bring in through private pay, insurance, Medicaid. It can be a mixture of funds.
Other questions? Senator Pope.
Thank you, Mr. Chairman. A question, just the 988 seems to be really working and seems to be very helpful. But my question is this: when I dial 988, am I talking to someone in Mississippi, or is that a contract service somewhere else?
That's a great question. So 988, it's a national number, but it's routed based on your area code. So when you call in the state of Mississippi, you're going to go to one of two call centers that's in the state of Mississippi. So you're going to get a trained counselor in Mississippi that knows Mississippi resources. If those trained counselors are all on another call, it rolls to the next state. But in Mississippi, we have one of the highest in-state answer rates in the nation. In June of last year, we had the highest in-state answer rate in the nation. It was 96%, but we're always 90% and above, which means 90% of the time when you call in Mississippi, you're going to get the Mississippi counselor, which is important because they know the resources and connect you with the resources.
And that is a contract center.
Yes, that's right. That's right. It's not directly operated by the Department of Mental Health. They've never actually been funded through us, or a very little amount. And then when Congress passed legislation for 988, federal dollars were also given, and the legislature provided ARPA funds, and we've been able to provide grant funding to those crisis call centers to where they can increase their staffing because their call volume has increased. There were right at about 14,000 calls last fiscal year to 988 in our state.
Okay, thank you. Thank you, Mr. Chairman.
Any other questions? Yes, sir, Senator Wiggins.
Thank you. Thank you, Director Bailey. I want to go to the slide where you talk about your proposal. And you talked about moving number 3 to number 1. And my question is going to be if you could comment on more of that. And
Okay.
what I've seen is what happens is, to your point about the officer who goes and picks up the person, they have a writ from the judge.
Right.
That officer who's charged and taking an oath to carry out the orders of the court is not going to violate that.
Right.
And what I've seen is the family member, somebody, all they know is they walk into a chancery clerk's office, sign an affidavit, and there's no, let's just call it vetting that goes on. So the affidavit is signed, and boom, it goes straight basically to the law enforcement, who then has to enforce that.
Mhm.
Am I accurate in describing that? Is that in part why you're wanting to move number 3 to number 1? And then if we do that, what is your vision of how that can take place?
You said it perfectly. That's exactly what happens.
Mr. Chairman, I want that recorded that I said something perfectly.
He did.
Flying squirrel will find a nut.
You did. That's exactly what happens. And what we want to see happen, and again, it goes back to those court liaisons. That's what's happening there. You go into the Chancery Clerk's office where we have these court liaisons piloted, and you're connected with the court liaison, who then works to see, is there a CSU bed? Can we get you there? Do we need a 72-hour hold? Works through the process. Can we get you intensive services? So all of those things happen on the front end. If the commitment is still needed, the pre-evaluation screening's done, and if the community mental health center still recommends civil commitment, which they are in cases, there are individuals who need that level of care, then the affidavit is filed and the writ's issued. But they've been seen for that pre-screening before that occurs. And again, this is not to place a burden on the family, because when the family walks in, they don't know what to do either. I've been there with a family member before. It's an extremely emotional and process. So this is not to burden the family, but this is to make sure that the family knows their options and their loved one knows their options, and they get the care in the quickest manner that they can as well.
If I may. So, presently under this system, what it seems like is you have let's just say, a deputy chancery clerk who is doing amongst 100 other things, and then they handle one of the jobs, or one of the things they handle is people in a crisis situation signing an affidavit on that. Are these deputy clerks, do they even have the training for the wherewithal, if you will? And I'm not blaming them. I'm just saying it's almost like they've been put in a situation that's almost set up to fail.
I would agree with you. We do not provide them any training. They do not receive any training. And some of them work really closely with their community mental health centers, and they have a good partnership. And that's what we want to encourage. And that's what this would do. is this would put that with a mental health professional.
But when you're in Jackson County or Harrison County or DeSoto County or Lowndes County, you not only have that, but you've got everything else that's going
That's
on in
right.
the Chantry system.
That's right, it's one of many hats.
Thank you.
The gentleman from Pike? Holmes.
No
Sorry.
place like Holmes.
Senator,
Yeah.
Representative Bryant.
Thank you, Mr. Chairman. I want to follow up and piggyback just a little bit. I had an honor sometime to represent individuals who are in civil commitments there in Holmes County. Now, have any thought been given to the actual writ, giving more trainings to those referees to not just rubber stamp those affidavits when they come and issue the writ, but actually look into, the allegations that have been made in that affidavit to really make a decision about it? I think from the ones that I've seen, the writ is issued, the affidavit is filed, it's sent to usually a private attorney who's serving as a special referee, a magistrate, and they glimpse over it, they stamp it, they pick them up. Sometime if you was to just read the actual affidavit itself, it would shed some light on the fact that they might not be an immediate danger to themselves. So have any thought been given to giving more training to these referees or magistrates?
I think some of that would be addressed here, because you're right, the affidavit comes in and it's just filed and the writ's issued, because the Chancery clerk's doing what they need to do. They're not trained in diversion and what resources are available. So the writ's just issued. So I think the moving of the pre-eval to the beginning will help with some of that, because you would have someone reviewing that case and that file and that individual before then the affidavit's filed and before that writ is issued. Does that address? Okay.
I know the House members are running up on our session, but I want to first say thank you to all the House members and senators that have been part of this series of hearings. We appreciate your time and efforts. Senator Bryan has a question or comment.
Well, just sort of wrap up quickly, I keep hearing this discussion of the 70-year-old parent who needed help. As a practical matter, a lot of times the family could get that individual down to the crisis stabilization unit. All in the world you have to do is drive the individual to the crisis stabilization unit, have the sheriff meet you there. The sheriff can serve the writ, and the individual's already at the crisis intervention center. That's an example of things that can be done out in the various counties. And just by way of summary, I would say there are two things we need to do. Number one, we have to have services out in the counties that are available in fact and accessible in fact, so that there are alternatives. And B, we have to change behaviors out in the counties. Those are two things that have got to be done if we're going to improve the situation. Other than that, as far as, I'll just mention about tomorrow's hearing. Tomorrow, we'll meet at 3 o'clock up above. We will rise above tomorrow at 3 p.m. Look forward to seeing you all there. Chairman Creekmore.
Thank you, Director Bailey. Let's rise and report.
Thank you.
Yeah, Brian, I don't know.